Thank you very much. I realize I exposed myself to ridicule coming to Chennai with a topic coming from the UK, saying lessons from the West. But what I want to try and do just in the next few minutes is just look at some of the things that have happened in Europe and America. I will focus on Europe and UK. What I want to try and cover is that a few, what I think are key points. We have to have cadaveric donation. Living donation is valuable. It allows access to transplantation, but it is not a solution to the problems that people face with end-stage organ disease. So we have to have effective cadaveric donation. And we have to understand what the requirements are for effective donation to take place. Some of the things I'm going to briefly cover, and we've heard very well expressed just now, government oversight and regulation for public respect and understanding of the process. Providing an infrastructure that delivers what you want. Key and consistent funding to deliver what you want. And what I would call, and what we've just heard, which is evangelical leadership. Not of a particular faith, but of a particular type that leads and provides inspiration. And what we've just heard now, what's happening in Tamil Nadu, is access to care. And finally, transparency of use and outcomes. So that's what I'm going to do. So this slide shows my idea of nirvana. Here we have Spain, the most successful country in the world with organ donation. And some regions of Spain have deceased donation of 40 per million population. Can you imagine applying that to India? There'd be no time for conferences. You'd all be back home working. You'd all be experts in transplantation. So how did Spain do it? Well, they do have a framework of legislation. Their citizens are required to opt out to officially register objection to becoming donors. So if you're taken into hospital post-trauma or post-cerebrovascular accident, the state assumes that you are willing to be an organ donor. Now, I think this is really important, not because it's telling the public this is necessary, but it's informing healthcare workers. And I think the biggest barrier to effective organ donation are doctors and nurses, often quite close to intensive care. There seems to be an ingrained resistance to adopting protocols that produce donors. So I think legislation may have a role, may be important, but it's directed towards healthcare workers. And in Spain, very simply, starting in 1989, they showed that with this planned program, they could increase organ donation dramatically. The program actually cost, when they set it up, $5 million a year. The estimated cost saving by 1993, just from kidney transplantation, was $50 million a year. It was the only country in Europe where dialysis rates were reducing and there was no significant waiting time and no living donor program within that country. So that seems to be extraordinary. And the US, when they adopted similar plans, not through opting out, but through active donation and campaigns, they too could increase organ donation significantly. So the so-called Spanish solution, I've said there's a legal and technical framework for transplantation. They have a network of doctors who work as transplant coordinators. I think this is probably important. The doctors are based in the hospital. They're accepted within that environment. And when they get tired of organ donation, when their performance drops off, they can go back into their role as a doctor within the hospital. And they have coordinators in every hospital. As we've seen, even here, it's not just large hospitals with big neurosurgical centers that are important for donation, but to maximize the programs, need smaller hospitals with donors coming up less often that make a huge contribution to the overall donor numbers. And you need a central office to coordinate all of this, to drive it forwards. You have to have some sort of quality control monitoring so that people understand what goes on and the decisions that are being made. And the Spanish showed that intensive training programs for personnel do work. So when they went to northern Italy, they got northern Italy up from 10, 11 donors per million to 40 donors per million population. And the same in Uruguay. In Uruguay, over 3 years, they took organ donation from about 4 or 5 per million up to 20 per million population. So intensive training is key. Payment for donor hospitals. It costs money to maintain donors on intensive care. Hospitals should be remunerated for that. And as part of organizing healthcare, you have to have sufficient intensive care beds for that donation to take place. And the point has been made already. You have to have good news. Press offices have to be putting out continuously stories of the benefits to the population of transplantation to encourage people. So is opting out important? Well, in Spain, it's a very good framework to start the conversation about organ donation. I don't personally believe it's absolutely necessary. They showed that you have to have money and commitment. I've already said about the intensive care capacity. But it's really about organs for transplantation being seen as an opportunity to improve care for people. And as I say, it is an evangelical system. But what I love about the Spanish system is they still look for donors lost, to see how they could do better, to push it forwards further. And even within that system, they could identify approximately 40% of donors were lost during this process. And they could attribute that loss to healthcare personnel and their attitudes in 1/5, poor care of the donor within that institution. Still, despite the law, despite this positive attitude, family refusal of 23%. That sounds high, but in South London, around our hospital, family refusal rates run at 49%. So it's a huge source of loss of donors. And I would say public education and having families feeling confident about care within the hospital environment are important aspects of donation. And I do love this statement. In all of their papers, they say there are still opportunities for improvement. So this is Spain. When you see the green line, Spain is a country of 40 million people, and they do 1,100 liver transplants a year. That's a fantastic achievement. So that's the model for India to be aiming at, and I'd like to see you cope with the number of transplants. And even within that system, there's an important message. This shows Spain and deaths on the waiting list. Even within that fantastic system, you continue to have deaths on the waiting list. This shouldn't be a target related to organ donation. These are sick people. They need treatment. They need treatment within a finite period because we can't support them. But there will always be a mortality rate, and it's defining what's right. In the UK, you can see here on this slide, going back 10 years, our organ donation rates were around 13 per million population, and our liver transplant rates were around 11 per million population. By and large in Europe, those countries that have opting out legislation are more effective at producing donors than those who don't. This is the UK as of this year. You can see that the number of donors has gone up progressively over the last 6 years. We too now have not the Spanish solution, because that was viewed as too radical. We have the English solution, which was by committee and took several years, but is now delivering improvements in donation. And you can see for the first time in the green line, the number of patients on the waiting list is falling, and that's the first time in many years. So the English solution has been, again, a network of hospital-based coordinators. Every hospital has a coordinator. There's been financial investment, £11 million per year for our system. There is a central donor registry where a significant number of the population have registered their support, their desire to be donors. There is required referral of every potential donor coming into the hospital being referred to the donor coordinator. And we have performance management. So I can show you various plots which are given to us month by month that record performance of retrieval and of outcome. This is really important. And we have dedicated retrieval teams to try and minimize loss of organs through damage. And now I hear in our documents that there are still opportunities for improvement, which makes me very cheerful. This is a big, busy slide, but it says, even within regions quite close to each other, there are major variations in organ donation and family refusal. So you have to be very consistent in terms of how to apply the drive, the lessons, and the publicity. So the questions that I have, I'm very pleased that you were also using questions. Is opt-in, opt-out important? I don't think it is. I think it's important to have the debate, but the problem, I think, is not with the public, but it's with healthcare professionals. There's often a deeply ingrained cynicism about the benefits of transplantation. Is a national donor registry an effective way forwards? Is it an effective use of money? I think probably not. However, we now have so many patients or people registered that it is gaining ground, but it's taken a huge effort to get about 1/5 of the population onto this registry. Can all countries use the Spanish solution? The answer is clearly yes. Uruguay could do it, Italy could do it, any country could. You have to maintain continuous good news about transplantation and recognize centers and expertise. But I think the challenges are the access to transplantation, actually the access to donation as well. I think it's quite difficult to work in an environment where you expect donation from members of the population who may not get access to that form of care. How do you address that? We've heard efforts locally here today. How do you get donation if the potential donor can't get access to the sort of care that would make them good donors? That's also a challenge. And donor maintenance. It costs money to maintain people on intensive cares. That money has to be provided for not by the donor and the family, but either by the state or some form of system for reimbursement. And the big challenge is public education, family refusal. The ability to pay for the transplant is seen as the major hurdle, but then you've got the hurdle, the challenge of paying for the transplant immunosuppression year after year. I like the Brazilian approach. It's very far-sighted. In Brazil, it's a federal right, that is, it's a national right for every citizen who's had a transplant to be able to claim reimbursement for their immunosuppression. So you don't have people who have transplants and die because of a lack of ability to pay for their immunosuppression. This is a fantastic socialist idea that works. And then finally, there's a need for transparency. With transparency comes regulation for both donation and transplantation, and of expecting standards of care for all transplant centers, minimum criteria to offer transplantation. There have to be nationally agreed indications for transplantation that don't stifle innovation. And at some point, you have to have equality of access. And as I say, you have to have audited outcomes, both for retrieval and transplantation. This is the UK. These funnel plots look at patient survival at 1 and 3 years. You can see by number and outcomes how people are doing. So if you're on the right and you're above the line, you're very good and you're very busy. And the types of liver I'm not going to talk about today. So just really to start winding up. Organ donation and marginal grafts. The problem with using marginal grafts is you lose fewer of them, and where outcomes are poor, it will damage donation. They're more complicated and they cost more, and it's important that people receiving these grafts understand it. You have to minimize cold ischemia because it's one of the few things that you can influence in this process. There will come a time where you need dedicated and experienced retrieval teams, potentially as part of a national service. So the targets for donation, what would I say to you? Well, it's organ utilization rather than donor numbers. It's multi-organ donation, and therefore it's heart-beating donation. Linking donation and outcome is very powerful. Rewarding donation, the families, the ITUs, the hospitals, I believe is key. Having an infrastructure based on the Spanish system with networks of really well-trained, targeted coordinators. Having someone at the center who's capable of performance management and of driving positive press, which is sustained, and that also is a real challenge. So I'd say to you, good luck. Building a transplant program is always fun. You're in a building phase, and the early years, I would say, are always those that are most fondly remembered. Thank you.